Hello, I'm Steve Betschel. I'm a clinical immunologist and allergist at the University of Toronto in Toronto, Canada. And it's my pleasure to be asked to talk about HAE therapies, both currently available in Canada and what we hope to see in the future. One of the hats I also wear is as chair of CHAEN, the Canadian Hereditary Angioedema Network. And this organization has been, since its inception, very much focused on the development and publication of treatment guidelines. The most recent iteration was back in 2019. The goal of those guidelines is really to keep patients and treaters, as well as other advocates, informed of the developments around therapies, what's available, and when they should be used. I was fortunate enough to lead that initiative in the most recent iteration, but it certainly wasn't an individual effort. There were several treaters across Canada involved in this, many from Quebec, as well as a number of international experts who are involved in this process. What I'd like to do is talk a bit about the treatment landscape as it's evolved. And what I'll do, I think, is maybe start with acute therapy. And we have to remember back, about a decade ago or more, just over a decade, we really didn't have a lot of therapies to treat HAE, certainly not licensed therapies. Most of the treatments were focused on attenuated androgens, such as danazol or tranexamic acid. These were used either for prophylaxis or for long-term prophylaxis or short-term prophylaxis. Although C1 inhibitor could be obtained, it had to go through special access in order to obtain it. It was licensed just over a decade ago for the acute treatment of HAE attacks. Again, this is an intravenous therapy that many may still be using to treat acute attacks. The other option that came along not long after was Firazyr, or icatibant, subcutaneous small volume injection, bradykinin receptor antagonist that would be used on demand. That's really where we're at still in terms of options available for acute therapy. What about pipeline drug development for acute therapy? There are companies that are looking at oral agents, oral kallikrein inhibitor agents, but you can imagine how wonderful that would be if you could take a pill to treat an attack. Probably where we've seen the most in terms of development is in long-term prophylaxis. So in Canada, what was licensed initially was C1 inhibitor, Berinert, for acute therapy, but we know that many patients and treaters used it for prophylaxis, both intravenously initially, and when the concentrated formulation came along, it was being used subcutaneously because we knew it was essentially the same drug. It's now available as Haegarda, which is licensed and indicated for subcutaneous administration for prophylaxis in HAE types 1 and type 2. Cinryze is a product that has been licensed and is continued to be available for intravenous C1 inhibitor use for long-term prophylaxis. The landscape has continued to change, and the most recent new-in-class therapy would be lanadelumab, a fully humanized monoclonal antibody against kallikrein that's injected subcutaneously every 2 weeks, and then if patients are stable, can then be given every month. So that really is a summary of what's available, current treatment options available in Canada for both acute and long-term prophylaxis. I think what's important to realize is in most parts of Canada, in all parts of Canada, C1 inhibitor is distributed by the blood bank. Unlike monoclonal antibodies such as lanadelumab, which is not currently administered or distributed, rather through blood banks. This can impact the ability to have access to this therapy. The pipeline for long-term prophylaxis is also looking very favorable. So currently in Canada, we don't have available oral kallikrein inhibitors, but they are being used in other countries. We do hope that this will become available in Canada in the very near future. There are also being developed monoclonal antibodies and currently in clinical trials against activated factor 12, another exciting area that may be in the therapeutic regimen for long-term prophylaxis in Canada and hopefully in the near future. Some work is being done in developing antisense mRNA molecules, and those are in early development, and we hope to see that in the future as well. Remembering that HAE is a genetic condition that's autosomal dominant, mutations have identified in the SERPINE1 gene, and that does allow for the possibility of gene therapy. That also is being looked at, and hopefully in the near future, perhaps over the next decade or so, those clinical trials might go ahead for patients with HAE. So in summary, those are the currently available and what we hope to see available therapies in Canada for both the acute treatment of HAE as well as long-term prophylaxis. So we have been fortunate to see a number of drugs developed and come in to the landscape for treating HAE both acutely and more so for long-term prophylaxis. I think it's important to remember, though, that it is important to develop different drugs that act perhaps on different targets or even the same target, but perhaps administered through a different route. Not every drug is tolerated or is as efficacious in every patient. And it's very important to maintain options. And the drugs that are available because of the advocacy of patient groups and physicians to bring these to markets to ensure access as much as we can to these alternate therapies where they may be appropriate for some patients and work better, where they may not work as well in others. So it's very important, even though new drugs are being developed, to make sure that we have access to them so that they can be used in the appropriate patients, in the appropriate circumstances. And lastly, I just want to end by thanking the patient group for asking me to speak at this meeting. It's so important, and we've always worked so closely with patients. And I truly believe that bringing together patients and treaters to continue this ongoing dialogue so we can advocate together for access to appropriate treatments for patients with HAE.